So, myself, Dr. Rujul Jain, I extend a warm welcome to all the attendees from on the behalf of Medanta Endocrinology Department. So, in our endeavor to share latest insights and updates on the common clinical conditions, we are here with the MEND Clinical Update, another series of the MEND Clinical Update. And I'm sure it will be an enriching and uh, enjoyable learning for all of us because we have with us the stalwarts in their respective fields. The speakers are really, they will share their rich wealth of experience with us. So it will be a great learning experience for all of us. So I once again welcome all the attendees. To start our clinical update, it's a privilege for me to invite Dr. Sanjay Mittal, sir. Sir is the Senior Director in Department of Cardiology at Medanta Hospital, Gurugram. And sir will share with us his experience on the management of heart failure, both with preserved as well as reduced ejection fraction. Over to sir.
Thank you, Rujul. So, first of all, let me welcome all the delegates and all these listeners. Today, the very fact that I am here and speaking in endocrinology meeting is emanating from two very important things. Point number one is there is hardly any differentiation between cardiology and endocrinology today because it is all metabolic syndrome, which is killing most of us. Even if you are a diabetic, the most of the times what kills a person with diabetes is a cardiovascular outcome. And I am going to talk about the heart failure management. There's probably nothing in this world, specifically in the field of cardiology and diabetology, which is moving in the menacing speed than heart failure management. For last 10 years, since the time ARNIs were discovered in the field of heart failure, there's no stopping on new developments in this field. I'm going to dwell on what is the latest updates. Some of them I'm going to hurriedly talk about because this is which is in common knowledge for everybody. But certain things which I'm going to dwell about a little bit more detail with the paucity of time because, as I said, it's a growing development in heart failure. And probably if I keep on talking about the heart failure, new advancements, probably half an hour, even 2 hours is going to be less. What I wanted to spell out is emanating from this particular thing. So many changes in the guidelines, updates, and management and things over the world. If you look at the European guidelines emanating 2021, Canadian new guidelines 21 again, Japanese guidelines in 21, American guidelines 22, even if that was not enough in 23, we had a focused update on European guidelines in 2021. So much of things happening that each year, almost each year, the guidelines have to be updated, changed, and brought with a new concept. So that is something which I'm going to be focusing on in my deliberation. The first thing, as very rightly pointed out by Dr. Rujul Jain, today we have heart failure with reduced ejection fraction, preserved ejection fraction, as a concept for people suffering from breathlessness or intolerance to activities, having reduced ejection fraction that is less than 40% LV ejection fraction or above 50% when they called as preserved ejection fraction. However, there is a huge bit of gray zone here. If you look at, there are people with between 40 and 50. But these ejection fraction heart failure people are also diverted into two categories, depending upon the trajectory. That means people who have had slow downfall and first time detected to be ejection fraction in mid-range, they are called as a mid-range ejection fraction or mildly reduced ejection fraction. We use acronym of MR. So heart failure with mildly reduced ejection fraction, where the first reading is being detected to be between 40 and 50. But on the other side, there is a trajectory when initially the ejection fraction was less than 40, but now the ejection fraction has improved to above 40 and falling between 40 and 50. So this is something which we now call as heart failure with improved ejection fraction rather than preserved ejection fraction or mid-range ejection fraction. All of these have different connotation and outcome data which is available for us. If you look at American College of Cardiology AHA guideline 2022, this again classifies heart failure into various categories and incorporates the very fact that the classification of heart failure is never static. It is a continuum, which means initially, if you rank the heart failure as heart failure with reduced ejection fraction, with management, if the heart failure improves, this is called as heart failure with improved ejection fraction, or the heart failure will remain with reduced ejection fraction. Similarly, the heart failure with mildly reduced ejection fraction may have all three outcomes, whether on the follow-up, it may fall below 40, reduce ejection fraction, remain in 40 to 50, mildly reduced ejection fraction, or it may improve to above 50. There is no specific term given to this. It's still not called as heart failure with improved ejection fraction. This is still a gray zone where the terminology has yet not been imparted. On the other hand, heart failure with preserved ejection fraction may land up with an ejection fraction less than 40, then we call as heart failure with reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction. That is important note that it is a continuous process. Heart failure with reduced ejection fraction, because this is the time where the maximum development of understanding and heart failure therapies have developed. If I look at today and summarize all the developments, this could be summarized into this particular field. One, we have success stories determining in 5 pathways. And what are these 5 pathways? Few of them are already known. The angiotensin 2, whether we call it ACE inhibitors or angiotensin receptor blockers. This is the pathway which has been a success. Norepinephrine through the beta blockers, we all understand. Aldosterone, because this is our third pillar, mineralocorticoid receptor antagonist, which we have plerinon and spironolactone, 2 pillars here. The fourth pillar, pathway is the neprilysin. And when the ARNIs came on board, which is angiotensin receptor blocker at one end and neprilysin inhibitor on the other hand, a combination of 2 compounds, sacubitril valsartan, this was the addition of the 4th pathway. But latest, not the least, which is most exciting to the endocrinologist, that their baby is grown so big now that it is going beyond the realm of endocrinology alone and in the control and complete cardio, metabolomic, cardiology, and nephrology purview as of now. Probably one of the pills today, if we think that we can dissolve in the municipality a tank of water and probably every Tom, Dick, and Harry can have it in some other way form. Well, that is a questionable statement, but probably that's where we're heading to. The SGLT2 inhibitors, which possibly all of us would knowing, predominantly acts through the kidneys by reducing the reabsorption from glucose, and that's why it was discovered as anti-diabetic. But today, the value of it is not just the anti-diabetics or a diuretic effect because of the glucosuria, but also it's a direct cardiac metabolic effect, which leads to improvement in cardiac energetics, leading to improvement of cardiac output, cardiac performance. And that is why it is today the 4th pillar for heart failure with reduced ejection fraction. So these are the 5 pathways. And on the basis of the 5 pathways, the 4 drug groups, one is the ARNIs, ACE inhibitors or ARBs, which is something ARNIs are going to replace now that the costs have come down. The other thing is a beta blocker, which today we are talking about either carvedilol or bisoprolol or metoprolol succinate, not metoprolol tartrate. And nebivolol also very much reserved to only high-end, high-age people. The data on general population for the cardiac output, cardiac benefits, outcome benefits in heart failure is not yet there. So only 3 compounds. MRAs, as I've already mentioned, finerenone yet is not a part of it because most of the studies have been focused on finerenone in diabetic kidney disease, not in the heart failure perspective. Although in the perspective which they have been used in diabetic kidney disease, they have shown heart failure hospitalization reduction and mortality benefit. Yet not generalized, but in that perspective, probably it's going to be better as compared to the other MRAs, but the data is not yet there. SGLT2 inhibitors, we have already talked about, but 2 things which we have focused about is dapagliflozin and empagliflozin. Data on sotagliflozin is deficient, unfortunately, because soloist WHF trial, which was in diabetic heart failure preserved ejection fraction, was prematurely terminated because of the COVID fiasco. Although the later publication on the investigator adjudicated events showed it was substantial benefit, giving a combo of SGLT1 and 2 blocker, which is the sotagliflozin. However, till that time, the yardstick is still dapagliflozin and empagliflozin as a class 1 indication for heart failure with reduced ejection fraction. There are certain more compounds which are to be discussed here. Ivabradine, which is for people to reduce the sinus rate, people who have persistent tachycardia above 70, not tachycardia, but heart rate above 70 beats per minute when they are in sinus rhythm, and they, despite beta blockers, are not able to bring the heart rate below 70. That is the time we add ivabradine to reduce the heart rate and to give them mortality, not mortality, morbidity benefit of hospitalization. Hydrolyzine nitrate, the old story, not yet investigated beyond the Black population, African population in the HEF trial, but still it is a drug of choice for people who have advanced CKD, not being able to give ARNIs and other things, and have heart failure with reduced ejection fraction in that scenario. Vericiguat is possibly heading towards becoming the 5th pillar, although the data which we have today is just based on the Victoria trial, which was taking in consideration of worsening heart failure, the worst heart failure population with reduced ejection fraction, where the expected annual mortality was above 37%. So that minded is a huge, horrendous situation. And that is where the drug was able to produce 10% reduction, which was statistically significant. And yet it is not approved as class 1 indication, all over class 2B indication for people who persistently continue to have symptoms or recurrent hospitalization requiring intravenous diuretics. That is the class where we use vericiguat. We are waiting for the results of Victor trial. Probably after, if the Victor trial also shows the same lines, this may become a class 1 indication. As of now, it is class 2 indication for people with worsening heart failure and having reduced ejection fraction. It acts through soluble guanylate cyclase inhibitor, stimulator, which is responsible for increasing the cyclic GMP, and through cyclic GMP causing vasodilatation and reduce the cardiotonic effect. So that is how it is beneficial in the long run for heart failure patient with reduced ejection fraction. Till the time Victor trial result is there, it's still a class 2 indication. So that is a summary of the heart failure with reduced ejection fraction. I have a few more slides to just give you the importance of these 4 pillars, which I have talked about on the various aspects of heart failure with reduced ejection fraction. First of all, the survival. Yes, the 4 pillars do improve survival. There's no rocket science. ACE inhibitors reduce mortality by 16%. ARBs, again, almost the same, 17% reduction. Beta blockers have the maximum improvement on mortality, despite the fact they were on add-on on ACE inhibitors, almost 34% as compared to the placebo in MEDITATIVE, and the similar kind of Copernicus and other trial results are there. MRAs, again, over top of ACE inhibitors and beta blockers, showed 24% mortality improvement. So this is cumulative. We start with ARBs, which did not have data with the beta blockers. This is add on with 34% reduction, then add on with MRAs trials, and then ARNIs. Over and above all these things, and plus a comparative not being a placebo but an ACE inhibitor, 16% more improvement in outcomes with a p-value so significant, so many zeros, probably no other trial had it. Paradigm HF, this is a history now, and this is a class 1 indication for replacing ACE inhibitors, ARBs, to ARNIs, people with symptomatic heart failure. SGLT2 inhibitors, 17% over and above all these things. So these are cumulative in enhancing the outcome benefit to the extent. And I think this slide is now not important. We have already discussed that SGLT2 inhibitors do impact so many things in the cardiac metabolism, in the renal function, and the diabetic portfolio, that it has a cardioprotective effect, reduces myocardial injury, and that's how it improves heart failure. If you look at the data, again, Emperor reduced and DEPA-HF, both of them showed in this particular perspective that the mortality benefit in the meta-analysis was there, although the Emperor reduced did not show a statistically significant mortality benefit, but the trend was there. If you look at the heart failure hospitalization or primary component of endpoint of first hospitalization cardiovascular death, everything was favoring the SGLT2 inhibitors. So this is why, and the other thing which is important is it does not need a person with heart failure to be a diabetic to produce the effect, because diabetic or non-diabetic, the benefit of SGLT2 inhibitors, both of them was there, and that is why it's now class 1 indication. As I said, it is a cumulative A, B, C, and D pathways. The cumulative effect is that if we have all the four pillars, almost 8.3 years we can add to the life of an individual as compared to when the person is not receiving one. And this is actually irrespective of the age to start. The best benefit happens as early. We can start at 55, 8.3 years, but the benefit is still continuing to happen almost 3 years, 2.5 to 3 years, even if the person has to start the treatment at 80 years of age. The second part about the 4 pillars I'm going to talk about is, can it reverse the heart failure remodeling in reduced ejection fraction? The maximum data today is available with the beta blockers, the Carmen study, which showed a substantial reduction with carvedilol as far as and systolic volume and ejection fraction increase is concerned as compared to the baseline. You can see enalapril would cause hardly any, but addition of a beta blockers cause substantial improvement, almost to 5-point improvement in ejection fraction. The effect with PROVE-HF, which was on ARNIs, was much more horrendous. Almost 9 to 10 percentage point improvement in ejection fraction was noted with addition of ARNIs and replacement of ACE inhibitors to ARNIs. So that is something why ARNIs are now considered to be class 1, to be replacing ACE inhibitors. So this is again the similar slide summarizing the data which I've already discussed. Another point about the 4 pillars is that they can change the heart failure class, and the data is absolutely fine. If you look at people with heart failure with reduced ejection fraction with 4 pillars, unfortunately, 60% of people would remain in heart failure with reduced ejection fraction, but almost 40% would improve their ejection fraction, and 20% may actually become almost normal ejection fraction. So this is something of the power of the heart failure medication in this terms. Summary again is this, that these 4 pillars, the MRAs, ARNIs, SGLT2 inhibitors, and beta blockers, but there are certain other things which we have to look at. If the person is not tolerant to ARNIs because of the renal dysfunction, potassium and creatinine, hydrolysin nitrate is an important drug of choice. We can also think about mitral edge-to-edge. ACE inhibitors and ARNIs, if the ARNIs are because of hypertension not being tolerated. Another word about the ferric carboxymaltose. If the person, almost 70 to 80% people with reduced ejection fraction have iron deficiency in the form of TSAT, transferrin saturation less than 20, and these people should be given ferric carboxymaltose because this improves their effort tolerance, this reduces the heart failure hospitalization, and this has a trend towards decrease in mortality. Studies are still continuing, small studies, but a lot of data today. The meta-analysis does show even the mortality benefit. So this is sooner or later going to become a class 1 indication. If a person has atrial fibrillation, anticoagulants digitalis may be a drug of choice, and evaporating we should think about. CRT, if the person has left bundle branch block. This actually is a beautiful diagram summarizing everything. But beyond this thing, I should not forget to mention about the fact that people with heart failure with reduced ejection fraction should be a candidate for vaccination for pneumonia as well as influenza. So that is something to be. Pneumococcal and influenza vaccine has a class in 1 indication because they have high incidence of vulnerability to these infections and subsequent mortality. So these are this is the nutshell of what we have: a heart failure with reduced ejection fraction, and the guidelines are now very clear on how to choose. One, we should choose all 4 pillars within the 4 weeks of the diagnosis, and we have to actually 1 week of diagnosis and try to build up maximum dose within the 4 weeks of the diagnosis of heart failure with reduced ejection fraction. We may have different scenarios. We may have people with low heart rates, then the choice is to reduce beta blockers and R needs to be scaled up. We may have people with normal blood pressure, then all the lines of treatment are possible. Rather, if the person is higher pressure, then isosorbide mononitrate hydrolysine combination may be good enough. So this kind of chart has been given to help us choose how to initiate and how to propagate our treatment choice. And this, unfortunately, it's so complicated. I would simplify in the terms that each individuals with a correct mindset of escalating the dose and reaching to the 4 pillars as early as the 4 weeks is what the criteria is. Depending upon the each individualized patient situation, looking at the blood pressure, heart rate, kidney function, the creatinine, EGFR rising or dropping, or potassium reports, atrial fibrillation, we can choose our armamentarium in the interest of the patient. A word about now heart failure with preserved ejection fraction. Mind it, till a few years back, there was no treatment available for heart failure with ejection, but there is a gray line along the crowd. And this is something which I'm going to discuss about. Point number 1 about the heart failure with preserved ejection fraction, that the incidence is growing. Almost 37% increase has been reported globally, and it amounts for more than 50% of the whole heart failure business in the whole world. Unfortunately, in India, it is still 25% of the whole population. But in the world, it is almost 56% of the population here, which suffers from heart failure with preserved ejection fraction. And the reason for that is, again, because the comorbidity is increasing, obesity increasing, age increasing, the diabetes, metabolic syndromes increasing, hypertension increasing, coronary artery disease increasing, which is leading to a higher incidence of heart failure despite preserved ejection fraction. And this is something which is I was talking about. Unfortunately, in India, the preserved ejection fraction is 15 to 20. If I include the mid-range, it is still 25 to 30%, which is still less. Probably it is underreported because the definition of heart failure preserved ejection fraction and the diagnostic dilemmas is still something which is hugely confusing. And many of the people with heart failure with preserved ejection fraction, unfortunately, end up with non-cardiologists. They end up with endocrinologists. So, for example, if a person comes to an endocrinologist with diabetes, you ask, are you symptomatic? Are you having breathlessness? No, I don't have. But do we ask them, how much do you exercise? They are obese very frequently. And when you look at an obese person, you ask them, how much do you exercise? They say, well, I don't have symptoms. But the guy is not walking enough to produce symptoms. If you look at the legs, they are swollen. If you look at their lying, they have cough in the night. They have intolerance while you climb stairs. So until unless we ask them, symptoms are hidden because of lack of their activity to the level of exercise symptoms. And that is why one. Secondly, most of the comorbidities actually lead to a breathlessness on them. The CKD, for example, atrial fibrillation, for example. So the breathlessness is a part of it. Age, if the person has advanced age 70, 80 years, you don't expect that person to be walking too much. So that is why it is commonly ignored and underreported, because these people fall in nephrologists, in non-cardiologists, general physicians, COPDs, arrhythmia cardiologists, and CKD and diabetologists. So until unless we realize this is an entity, we'll keep on missing the problem. And as I said, if you look at heart failure with preserved ejection fraction, so many comorbidities: lung disease, COPD, iron deficiency, anemia, renal volume overload, aging, obesity, as I've already described. These are the things which we keep on missing. And that is why the heart failure with preserved ejection fraction is commonly missed. There is a lot of discoveries and development in understanding a better heart failure pathophysiology. It's totally different from the lack of ejection fraction. It is a stiff heart syndrome where the extracellular matrix actually become more stiffer. The extracellular matrix is higher, more collagen there, and more fibrous tissue, which leads to stiffening of the myocardium. There's less of muscular tissue, and this is something which is a root cause of the stiff heart syndrome. They produce diastolic dysfunction. Also, there is a coupling between the stiffening of the vessels leading to increased vascular resistance and hypertension, and leading to load on already stiffer ventricles. So the ventricle is stiffer and the vessels are stiffer. So the combination leads to heart failure with preserved ejection fraction. Also, at times with advancing age, the compensatory mechanism for the stiff heart is, if the stroke volume is less, because the small size of the ventricle, the compensatory mechanism is to increase the heart rate. That's how the cardiac output will increase. Remember, cardiac output is the multiplication product of stroke volume times the heart rate. So if this stroke volume is small because of small ventricle, stiff ventricle, the heart rate should increase. Many of these people have a slow ventricular rate because of the aging of the sinus node. And this leads to a chronotropic incompetence, which is the third pillar of heart failure with preserved ejection fraction. And mind it, that is why these people do not respond to beta blockers, which are the pillar of heart failure with reduced ejection fraction. These people usually adversely respond to beta blockers. As I said, it's a diagnostic dilemma, but I would say that there are certain guidelines changes. So first is to suspect. Any person who comes to us with effort intolerance should be put on the suspect list. So there is a HEF2-PEF score, which is if the person is obese, heavy, BMI more than 30, you get 2 points. Hypertensive, again, you get 1 point, at least on 2 antihypertensives. A person presenting to us with effort intolerance. Atrial fibrillation, you get 3 points. If you have on echocardiogram pulmonary hypertension of more than 35 millimeters of mercury, you get 1 point. Age above 60 years, 1 point, and filling pressure of more than 16 millimeters of mercury in the form of E to E prime of more than 9, you get 1 point. So if you look at all the cumulative scores on these points, if it is more than 6, the person having a chance of heart failure is more than 90%. So this is how the suspect heart failure is given. But how do you diagnose? This is HFpEF, the Heart Failure Association of European Society of Cardiology, has given this HFpEF algorithm to not only suspect, but to diagnose. So diagnosis is initial workup, again on sign and symptoms, ECG and all comorbidities, as we discussed earlier. But if the person has an echocardiographic diagnosis suggestive of concentric ventricular hypertrophy, enlarged left atrium, E to E prime ratios, suggestive of increase in diastolic pressure, this person has heart failure with preserved ejection fraction. In certain people where the diagnostic dilemma remains that the person has effort intolerance, but the pattern of echocardiogram does not come true, exercise test would come into fore, and that should be advised. So these are the diagnostic algorithm which have been given by various organizations. So I'm coming now to the last part of my talk, which is heart failure with preserved ejection fraction treatment. This is what we had till 2021. You can see there is no class 1 indication. And only class 1 indication for heart failure with preserved ejection fraction was loop diuretics. And that also for symptomatic stabilization so that the person can at least breathe to the next day. But enhancing the life of those patients was not something that diuretics could do. So the treatment of heart failure with preserved ejection fraction till this time was volume management by diuretics, class 1 indication, but manage the comorbidities, hypertension, ischemia, atrial fibrillation, and if I have bradycardia, then talk about atrial pacing, and the other concomitant things to be managed. But no definitive treatment was there. And the reason for that was that all the trials which were done, this is something which is A, B, C, D, so many data which is available. And every trial, you know, if you took Candesartan, you talk about MRAs, you talk about RNAs, whenever the ejection fraction in this continuous, when we talk about the ejection fraction plotted on the y-axis and x-axis showing the benefit, this gray line shows that there is no benefit. That means placebo and drug is equal. Till the time the ejection fraction touches 55, the benefit is still there. But the moment it touches 55, the cross the line, that means the benefit is not there. It is as good as placebo. So you talk about Candesartan and the heart failure hospitalization. You talk about primary outcome or cardiovascular death, everything crossing the midline as soon as the ejection fraction touches 55. MRAs, again, the same story. The Top Cat trial, we all know who was there. And RNAs, the Paragon HF, again, the same story. As soon as the ejection fraction crosses 57%, but as soon as it crosses 50% in men, it loses benefit, the blue line. The red line actually went a little later, 57, that was the ejection fraction. But this is something which is unfortunately not forgiven. And today, they have had no indication for any of these molecules except for managing hypertension. Let's talk about SGLT2 inhibitors. Again, there are two trials which have come side by side. One in 2021, before the European guidelines came, and the second after the ACC guidelines came. The Emperor Preserved came first in 2021, and Deliver trial with dapagliflozin came in 2022. Both of them, for the first time, showed primary endpoint of composite of heart failure hospitalization and cardiovascular mortality to be beneficial. Although individually the mortality benefit was not there, but because both of the trials were speaking in the same line, and the heart failure hospitalization being a surrogate marker of future cardiovascular mortality, this is now a class 1 indication on the basis of both the trials to be given for people with heart failure with mid-range or mildly reduced ejection fraction and preserved ejection fraction. So as I said, the primary endpoint was individually, both of the trials showed almost 17 to 18% primary outcome benefit, but none of them showed mortality benefit. Predominantly, the heart failure hospitalization was the thing which improved, but the KCQ score was also improved. So that is why today this is a class 1 indication. Let's talk about the last part of my talk, the newest development of them all, the obesity. The obesity, the managing heart failure with preserved ejection fraction is something which is talk of the day today. And the SELECT trial and STEP-HF trial, there are two trials which have been reported in the last 4, 5, 6 months. And the SELECT trial results were just out 4, 5 days back when I was there in the US for the same. Both of the trials are based on semaglutide on the GLP-1 analog, which all of us endocrinologists have been using in people with heart failure with preserved ejection fraction. These drugs have been used in both STEP-HF as well as the SELECT trial in non-diabetic population. I don't have to go into the details, what is the modality of action, but this is something which is important because GLP-1 analogs improve vascular protection, improve microvascular function, they improve myocardial structure and functional genetics, and also improve insulin sensitivity. And that is how it reduces weight, it reduces inflammation, and a lot of other things. Let me quickly go through in the next 2, 3 slides about the STEP-HF trial results. This was a study which is about 590 patients, ejection fraction above 45, BMI above 30, all of them were obese, having symptoms of heart failure, NYHA class 2 to 4, and a KCCQ score less than 90 points. That's how they included. And this was given a once weekly injection of semaglutide subcutaneously against a placebo of the same magnitude, 0.25 milligrams, 0.51, and 1.7 milligrams in an escalating dose. And they were followed up for 52 weeks. The key exclusion, which was anybody with a diabetes or HbA1c of more than 6.4. For our practical purposes, we excluded diabetic population here, and a blood pressure or a recent heart failure hospitalization or those things. But these people did have to have elevated left ventricular filling pressure on cardiac cath or NT-proBNP or heart failure hospitalization within 12 months. So the outcomes, the criteria in both the groups were equally matched. And what was important is this was a symptomatic study where the persons with semaglutide showed from the baseline a substantial drop in weight, almost to the tune of 13 kilos or 10 kilos as compared to the placebo over a period of 52 weeks. And if you look at the quality of life improvement, there was substantial improvement in quality of life by almost 16 points as compared to 8 points in the placebo arm. If you look at their 6-minute walk distance, it improved again by 21 meters as compared to 1.2 meters as we talk about the placebo. And if you look at the inflammatory marker, CRP, it was again reduced by semaglutide significantly, p-value of 0.001. Small number, 500 odd, still getting some benefits. But unfortunately, there were no hard endpoints, heart failure, hospitalization, or mortality. And that is where the SELECT trial, which was recently disclosed, came up. Again, this was a high coronary artery disease or cardiovascular disease patients, people who had established CVD with a BMI of more than 27 and ejection fraction 45 above. The established CVD was in the form of prior MI, prior stroke, or symptomatic peripheral arterial disease. They were again randomized to receive 2.4 milligrams of once a weekly semaglutide versus placebo. And the primary endpoint was CV death, non-fatal myocardial infarction, and non-fatal stroke. Again, the exclusion was any diabetics or NYHA class 4, end-stage renal on dialysis, and recent CV event. They were quite better matched for the characteristics, BMI, and all those things. What was important was over the 48 months period of follow-up, the primary endpoint was statistically highly significant with a p-value of 0.001 to differentiate between semaglutide and placebo. Almost 20% relative risk reduction was obtained by addition of semaglutide as compared to placebo, with the background medication whichever the patient was having. This was composite of CV death and heart failure hospitalization. Unfortunately, the CV death did not lead to a statistically significant, but you can see there was a period of nonsense which happened where the diverging curves actually converged, almost coming down to a straight line, and then diverged again. They are still not able to find out what the reason was, probably during the COVID, the supply of the drugs or so many other things happening, but they're working on this, why the diverging curves converged and then diverged again. So there is yet something to be explained, but this is something, despite the fact, at the end of the day, there was a diverging CV death. Similarly, the heart failure hospitalization had a similar pattern. However, if you look at the all-cause death, it was still statistically significant, almost 19% relative risk reduction. It was also, this is a summary slide. I'm not going to go into the details, but it's speaking the same things which I have discussed now. It was safe. There are 2-3 points which I would end my talk here with. Point number one, the new emergence of diabetes was almost 70% less in people who received semaglutide as compared to those who did not. The same thing is happening when the people were in pre-diabetic range. They've become non-diabetic majority of points of time. There was a small decrease in blood pressure. The weight reduction, we have already talked about, almost 9 kilos of weight loss. But unfortunately, 16% of people on semaglutide had to withdraw the drug because of the side effect of predominantly nausea, vomiting, which we all know is a important fact. Probably we have to redefine the doses, go slow, and develop the time and again. So this is something which I would end my talk here. That today the summary of what we are recommending, semaglutide is still something which is too recent, not included into the guidelines. And after the American Society of American Heart Association guideline, this class 2 indication for SGLT2 inhibitors is now class 1 indication for reduction in heart failure hospitalization and CV death. So the rest of the things remain the same, which we had discussed out. Thank you. Thank you for your attention. I'll stop sharing my slides and I'm here for answering any questions there are.
Yeah, thank you, sir, for such an extensive and elaborate discussion on the management of heart failure. So there is one query from the audience, that is how to go about the incidental finding of grade 1 or grade 2 diastolic dysfunction found on echocardiography done in an apparently asymptomatic individual.
So for all practical purposes, grade 1 diastolic dysfunction is not a manifestation of heart failure. Grade 2 diastolic function could be a manifestation of heart failure if the person has symptoms. You can make the person exercise or make the person elevate the legs. When you elevate the legs specifically, then you increase the volume into the left atrium, and this leads to precipitation of heart failure symptoms as well as destabilization of heart failure. So that is something which we have to talk about. Otherwise, if the person has no effort intolerance, no change, rather when we raise the legs, the grade 2, so-called grade 2 diastolic dysfunction goes towards DRA or grade 1. This means this is not grade 2. This is a normal filling pattern and should not be confused with heart failure.
Dr. Mittal, is there any difference in the symptomatology between the two heart failures? Reduced ejection fraction and preserved. It is for us physicians who don't know much about this. Can we differentiate in a clinic if we know that it is heart failure, but which type of heart failure it is clinically?
Oh, wonderful. Shafi, the issue here is heart failure is effort intolerance, right?
Okay.
If the person is not able to walk or be active as much as his compatriots of his age and sex matched person would be, this is heart failure. So that is suspicion of ventricular dysfunction or heart failure. The question whether it is different in the person's presentation is is not something which is to be differentiated. Why? Effort intolerance, breathlessness, swelling in the legs is something which would happen in both. But if you look at the division, I have just written down a paper with Dr. Parajita. She is one of the audience here for one of the books, Updates on Heart Failure. Very clearly, more of the peripheral congestive symptoms are there with heart failure with preserved ejection fraction. But more of the central or respiratory symptoms are there with heart failure with reduced ejection fraction. Because when we have a stiff heart syndrome, the right ventricle, because of Bernheim's effect, gets a diastolic dysfunction because septum is hypertrophied or stiff, which leads to right ventricular filling problems, which leads to heart failure. And the right ventricular dysfunction leading to congestive peripheral congestion is much more early in heart failure with preserved ejection fraction. But symptomatic effort intolerance is still there. So you may have people with walking around but having leg edema. So that still is heart failure.
Okay. One more short question. You were there at the select. Do you think semaglutide will be approved as a class drug for this heart failure?
Limited data, because the population was not heart failure with preserved ejection fraction, very selectively pointing out to obesity. So it's not extrapolatable to all heart failures with preserved ejection fraction. In a select group of heart failure with preserved ejection fraction, specifically who are obese, more than 27 kilogram per meter square, well, yes, it may become a class 1 indication. Unfortunately, the mortality data is not there supporting the class 1 indication. But today, the trend is moving as the surrogate marker of mortality outcomes, heart failure, hospitalization reduction, and all. Obesity management, it may become a class 1 indication. A coronary artery disease event rate reduction, it may become a class 2 indication at least. We are waiting for the revised guidelines.
We may need further investigate these studies. Yeah.
I'm sure it's going to go beyond diabetes control. So that's what I'm targeting to, because all the population here were non-diabetics, proven non-diabetics, and that is something, or metabolic syndrome you call non-diabetic metabolic syndrome. So I am quite sure we have to have a revision of our kind of a cocoon vision, which is going to widen now.
Yeah. Rujul, any other question?
Yes, sir. There is another query. That is, what is the role of treating iron deficiency in heart failure?
A wonderful question. This is something which we have been arguing again. We have a class 1 indication to do iron check in all heart failure patients, reduced ejection fraction or preserve. But class 2 indication to give them ferric carboxymaltose. So this question we have been raking up time and again. If you are testing as class 1 and not treating as class 1, what is the fun about it? So one thing is very clear, oral and iron doesn't help. It is only IV iron, and with ferric carboxymaltose, which has almost negligible reaction or allergic manifestations, it is safe to give. But yet, I'm quite sure the guidelines are going to revise a class 1 indication now, and because today they are starting to label those class 1 indication to reduce heart failure hospitalization and to improve symptoms.
So is there any reason why oral doesn't help and IV help?
There are reasons. The hepcidin is one of the substances which is responsible for iron, not only absorption, but also for assimilation of that iron into the developmental stage. So a lot of things do happen in heart failure. One is the gastric wall edema does not absorb the iron. The appetite is low. They are usually nutritionally depleted. Second, the hepcidin does not allow the absorbed iron to be actually assimilated. The third thing is the bone marrow depletion function is there because of the so many catabolic substances going around, inflammatory markers going on. So that is why the bone marrow cannot utilize. So once we give the iron in a very high dose, directly IV, then the barrier is broken and it is able to utilize. The oral iron cannot ever get to that level. So there are so many reasons for the IV iron to be effective. And iron is not a component of hemoglobin alone. Iron is responsible for so many metabolic pathways, for oxygen delivery and for metabolic myocardial contractility and function.
Thank you very much. Rajul, you can conclude.
Yeah, thank you, sir. I think there are no more queries. So I once again thank sir for sharing his invaluable clinical experience. So now we move on to the next session of this clinical update. So as we know that similar to the ultra long acting basal insulin, now we have ultra short acting insulin as well. So to discuss about the role of ultra short acting insulin, both in inpatient as well as outpatient hyperglycemia management, we have with us Dr. Khalid Farooqi. Sir is the Principal Consultant, Department of Endocrinology at Max Group of Hospital. So I invite sir for his deliberation.
Yes, thank you, Dr. Rijal and the organizers. So I'll just share my screen. So is it visible and I'm audible? Yeah.
Yes, sir, visible.
Yeah. So I think it's a important topic considering the fact that there has been a lot of developments in terms of development of the ultra long acting insulin, where the purpose is to kind of reduce hypoglycemia and ensure that there is a proper glucose control, and that we are able to kind of bring the glucose in the exact time and maintain a exact time and range. Now, in that context, obviously, there has been a lot of development in terms of the ultra fast insulin also. So the basic we have so far, I mean, understood that we need to maintain the glycemic control in order to prevent microvascular and macrovascular complications, because all these things at a later stage leads to significant morbidity and mortality. And through various previous trials, DCCT, advanced PADT, we have proven that there is an importance of intensive insulin therapy, which reduce the risk of diabetes-related complications by nearly 25 to 30%. There is also a known fact that we have to individualize the treatment plan as per the patient so as to achieve a near normal glucose values. Although I mean we are able to kind of control fasting to a great extent, controlling postprandial becomes an issue because of multiple factors. Obviously, there are multiple variables involved, and so far we have not been able to mimic the exact physiological insulin release which happens when in a normal person without diabetes who basically takes his meal. So we are not able to replicate the exact physiology when we are using a subcutaneous or even a IV insulin. So this is the usual insulin chain. So there are the A and B chains, as you can see, connected by the disulfide bonds. And small changes in the amino acid leads to the development of various rapid-acting insulin analogs. The first to come was Lispro in 96, followed by Aspart 2000, and then Glulicin in 2004. Now, there has been comparisons of these rapid-acting insulin with the regular human insulin, and they have been found to kind of reduce reduce postprandial hypoglycemia, and even but the fact is that still, despite that, there is a difficulty in controlling the postprandial glucose rise, and that led to the various further investigations and there in order to kind of find out a better molecule to control the post glycemic excursion. So if you see the regular human insulin, the onset is between 30 to 60 minutes, and then it lasts for around 6 hours. And as compared to that, the other fast-acting or the analogs, these are have an onset of between 5 to 15 minutes, and the duration of action is around 2 to 4 hours. Because of the longer duration, sometimes there is a post effect like a hypoglycemia happening in around 5 to 6 hours in the post-meal phase. So some trailing effect is still there, which leads to a hypoglycemia. And as compared to that, when you talk about the aspart, the fast-acting aspart, there the action is less than 5 minutes, onset is less than 5 minutes, and it lasts for around 2 to 4 hours. So basically, if you see the regular human insulin, in that terms, there is a slight leftward shift when we are talking about the so if you see here the black bar, this is the physiological insulin release, and we have to basically mimic this curve when we are using either the subcutaneous insulin regimen. So to a great extent, the faster aspart or even the faster lispro is able to kind of mimic this curve. Now, even I mean, while going through this topic, I was just reviewing and even 10, 12 years ago, when because there was some deficit in terms of insulin which could kind of control the post-meal phase in this manner, various at that time also there was various approaches being developed so as to kind of find out ultra fast acting insulin. So you can use mechanical ways or formulation based strategies to kind of achieve this thing by increasing local blood flow through inhalational method, like if you use Afrezza or the inhaled insulin. If you see that curve, that would be, it will be closely mimicking the insulin curve that I showed in the previous slide, or using intradermal application of insulin, or spreading the insulin into a wider area, and with various formulations like adding excipient which promotes monomerization. We'll see in the next few slides how monomer and hexamers kind of affect the insulin release and glycemic control, and adding excipients which basically increase local blood flow. As I mentioned, that there are a lot of factors which kind of affect the postprandial control, because it could be vary from various types of insulin preparations or dose, whether it is in a soluble or a suspension form, what is the concentration. There are various concentrations, 40, 100, 200, even 500, although that is not available. Then what volume is being injected, difference in the injection site, whether it is being injected intramuscular, subcutaneous, what is the depth of injection, what is the site of injection, presence or absence of lipodystrophy, and then what changes happen in the injection site. So sometimes difference in temperature, physical activity, local variations like massage, those things, age, skin condition, those can affect the insulin absorption. So now, if you see commercial rapid-acting insulin formulations, these contain a mixture of insulin hexamers, dimers, and monomers. Whenever and it is the monomeric form of insulin which is active and which basically the hexamer or the dimer has to dissociate into a monomer to basically traverse into the vascular system. And this becomes the rate limiting step for therapeutic action because the delay happens here. So once this is injected into the subcutaneous tissue, the hexamer dissociates into dimer and followed by a monomer, which is the active form. Now, an ultra-fast insulin would contain primarily the insulin monomer and no insulin hexamers. But it is a difficult thing to do because as we see that preparing a pure monomer is very difficult because it is not stable. And whenever you have to add some excipients and other medications to kind of ensure that it remains stable. One of the reasons why these human insulin, it contains various other materials, like there is zinc, there is metacresol or phenol. These are basically added to ensure that it remains stable in the vial or the in the insulin vial. So as you can see, so once the insulin is injected, the monomers would take around 5 to 10 minutes to get absorbed. The dimers would take around 20 to 30 minutes, and the hexamers would take around 1 to 2 hours to get absorbed, which basically results in the prolongation of the insulin action. And if you see the ultra-fast absorbing insulin here, so this gets absorbed quickly, so the onset time is less, and also there is a shorter duration of insulin action. So this basically reduces the risk of hypoglycemia at a later time. Now, as I mentioned earlier, that hexamer-free ultra-fast insulin will face stability challenges. Why? Because what happens is that once a monomer is there, it will interact with the especially at the air-water level, and this monomer basically is converted into amyloid fibrils. So because there is because these monomers are not stable, and so there will be conformational changes once there is a interaction between the interface. Now, if no stabilizing excipients are added, then these amyloid fibers can basically lead to conditions like insulin amyloidosis, which in fact will increase the, it will first of all increase the dose of insulin required to control the glucose values. And also, and once you use a stabilizing polymer, it prevents this interaction and it allows the monomer to remain stable. So this prevents any insulin amyloidosis. Now, the other thing is that there is a difference in the both the pharmacokinetics and pharmacodynamics of the older insulin therapy. Like, as I mentioned through these slides, that there is a slower absorption, slower onset of action, and then the requirement of it to be administered approximately 30 to 40 minutes prior to a meal, which kind of becomes difficult in various settings. And then there can be some hypoglycemia, especially late postprandial hypoglycemia with this. So ideal scenario would be that as this glucose starts rising, once a person eats, there should be a rapid release of insulin, which will basically cause a glucose disappearance. If this happens too little, then there will be a postprandial peak in the glucose values. If there is a insufficient, or if it becomes too late, then there will be a late hypoglycemia, because the peaks will not coincide. So an ideal, in order to achieve an ideal postprandial glucose values, we have to inject the right dose, and also the time has to be correct. Now, as I mentioned previously, that bolus insulin analogs have been compared to the human insulin, and overall the analogs have been found to be better in terms of achieving glycemic control and lowering the length of stay in general. So when we talk about the ultra fast insulin, currently we have Fias, that is the insulin aspart. This was approved in 2017. This is basically insulin aspart, which is combined. These are the excipient sartans, that is vitamin B3, which basically increases the speed of initial absorption, and various amino acid which aids in stabilizing the formulation. And then in 2020, basically the fast or the ultra rapid acting insulin Lispro, which comes by the brand of Lyumjev, was launched. Now it is available in India also. So I'll be briefly discussing about these molecules in the next few slides. So if we study the pharmacokinetic and pharmacodynamics of the faster aspart, you can see that as compared to the usual conventional insulin aspart, again there is a leftward shift in terms of the way the insulin concentration increases once the dose is injected. So this is like A is at 300 minutes and this is at 120 minutes. So again, there is a difference between these two. The blue one, basically the faster aspart, again has a leftward shift. Then in terms of disposal of glucose, here also there are two in C and D, you can see at 2 hours and 3 hours. Again, there is a leftward shift. That is, there is a increased glucose disposal by faster aspart as compared to conventional insulin aspart. So basically, we can conclude from this that there is a 5-minute earlier onset of appearance as compared to aspart, a 2-fold higher insulin delivery in the first 30 minutes, and a nearly 74-75% greater glucose lowering effect is observed. And also, the offset, that is once the insulin exposure or ends. So this around happens 12 to 14 minutes earlier with the faster aspart as compared to the insulin aspart. So for the faster aspart, the basic trial was the onset study. I'll not go into the details, but in the onset one, basically the aspart was compared with the insulin detemer, and the faster aspart provided basically a superior mealtime postprandial control, but overall there was not much of a difference in terms of severe or glucose confirmed hypoglycemia. Then in the same onset one, which was then the duration was around 52 weeks, where here the detemir was given once or twice daily. Here also, again, the main factor was the better superior 1 hour postprandial increment. So, and again, no difference in terms of hypoglycemia. In onset 8, which was again in type 1 diabetes, here it was here it was combined with basically insulin degludec. So aspart versus faster aspart, where the basal insulin was degludec. Here again the hypoglycemia was nearly similar, but the hypoglycemia happening around 3 to 4 hours was less with the mealtime faster aspart. And there was a non-inferiority in terms of the change in HbA1c. And in patients with type 2 diabetes, the onset 2 again showed that no difference in terms of hypoglycemia, but post-meal hypoglycemia here within the 2 hours was slightly higher with the faster aspart as compared to the aspart. So and in onset 3, that is again basal bolus regimen was versus the basal insulin. Here again, there was reduction, again, better postprandial control with the faster acting aspart was seen. Now, if you are kind of switching between the other insulin or aspart to faster aspart, then there is no need to change or reduce the dose. So you can switch from unit to unit, and the usual, as per the manufacturers, basically will follow the same bolus dosing, and adjustment pattern remains the same. So you can decrease by 1 unit if the preprandial or the bedtime glucose is less than 71. If it is between 71 to 108, no change. And if it is like going beyond 108, then you can increase by 1 unit. The other thing is that the insulin can be injected at the start of meal or within 20 minutes after starting the meal into the abdomen, thigh, or the upper arm. And obviously, rotation is advised. Now, the thing is that there are possible mechanistic associations, which is seen with the postprandial rise in terms of some abnormalities in the triglycerides and ApoB levels, endothelial dysfunction, and then increased arterial stiffness. So obviously, one would try to focus and try to reduce this glycemic excursion. Now, the ultra-rapid insulin, various trials have been done, and if you see the meta-analysis in terms of the change in HbA1c, as you can see here, there's not much difference when we compare the rapid acting insulin with the ultra-rapid insulin. Okay, and that stays true both for type 1 as well as for type 2 diabetes patients. But if you consider the 1 hour postprandial increment, in that scenario, there is a definitive improvement, and it favors the ultra rapid acting insulin in both type 1 and type 2 diabetes patients. So in terms of the management, like obviously the use scenario is both in terms on an OPD basis as well as in the IP setting. Obviously, the next speaker will be dealing with the management of hyperglycemia. So, in terms of the use of this kind of insulin for the hospital stay, obviously we know that there are certain challenges once a patient gets admitted. So there is a reduction in appetite. Patient can be NPO for various procedures or surgeries, and then there is an increase in the stress hormone, which causes increase in the glucose values. And also the meal timings also varies. So if in case of a regular insulin or even the rapid acting insulin, there can be a mismatch between these peaks. So both hypoglycemia as well as hyperglycemia can becomes a challenge. So in terms of the flexibility, so we can kind of use this to reduce hypoglycemia, especially if the meal timings are not assured. Also, if the eating behavior is variable, especially in the elderly, those with chronic kidney disease, liver disease, there also it becomes useful. Tube feedings also definitely it will have a role, because the duration would be close to around 4 hours, which will mimic the way we can kind of repeatedly give without the fear of stacking. Now, in case of the critical care setting, when we are using IV injections, there also the fast-acting insulin aspart can be used. As far as its compatibility with other solutions are concerned, so it is compatible. We can add it to sodium chloride and 5% dextrose. And for infusion bags, the polypropylene infusion, it can be injected into NS or 5% dextrose in a polypropylene infusion bag. Then as far as the various case scenarios, it can be used subcutaneous, IV, as well as in the pump. Post meal, we can use within 20 minutes of the meal. It can be used in elderly. It is approved for pediatric use also. It is also can be used in gestational diabetes. I'll show you some data later on. And obviously in the renal and hepatic impairment. So as far as A1C is concerned, there is no comparable difference between the two. But definitely there is in terms of hypoglycemia and postprandial reduction, definitely this scores better as compared to aspart. So now a few a word about the ultra rapid Lispro insulin. So again, here also the physiology remains the same, that the purpose is to kind of mimic the peak that is achieved by insulin once it gets released from the pancreas. And here in terms of Lispro, this is done by adding citrate, which basically speeds the insulin absorption by enhancing the vascular permeability. And the other is the treprostinil. Basically, this is again this kind of molecule is basically used for management of pulmonary hypertension. So this causes local vasodilatation, which enhances the absorption. But by the moment it gets injected, it is undetectable in the plasma. So there are no systemic effects. So here also it is same that these hexamers are converted into monomers, but because of the presence of these excipients, there is a local vasodilatation which promotes and also change in the increase of the permeability, which leads to faster absorption. So when compared to the rapid acting insulin, the ultra rapid Lispro has a 5-minute faster appearance in the serum, and within 15 minutes of injection, there is a 8-fold higher insulin exposure, as you can see here. And there is a 43% less insulin exposure once 3 hours have elapsed. So reducing the risk of hypoglycemia in that phase. And in terms of the duration of action, the action starts within 10 minutes as compared to the rapid acting analogs. And there is a 3-fold increase in the glucose infusion. That is, again, the glucose disposal is more as compared to the rapid acting analog. So glucose infusion rate, as you can see in the red bar, there is a leftward shift. So when we compare the ultra rapid Lispro with the other rapid acting insulin, same, as you can see, there is a comparison with Lispro aspart as well as the faster acting aspart. So the red one is the ultra rapid Lispro, and the blue one is the faster aspart. So this one had a fastest insulin absorption. So the 50% of the Tmax, that is the absorption, was reached within 13 minutes, and it was around 19 minutes for the aspart. And in the first 15 minutes, again, it was around 1.5 times as compared to aspart, and 5-fold versus when compared to the Lispro. So in the first 15 minutes, the exposure was better with the rapid acting, the ultra rapid acting Lispro. So again, this demonstrates basically that there is it kind of mimics the physiological glucose control. So here also the administration is similar, that can inject it before and around 20 minutes, within 20 minutes of the meal. Now, So here also the same thing, that because of this, the flexibility, um, it can be utilized in various case scenarios, as I had mentioned earlier. So both in inpatient and as well as in the outpatient setting. So this basically the ultra rapid Lispro has been compared with the rapid acting analogs in the type 1 and type 2 patients in the Pronto basically trials. I'll not discuss the details, just show you that in terms of A1C reduction, it was non-inferior to Lispro, and in terms of the controlling the postprandial glucose values, there is a definitive, you can see that there is a definitive difference, significant difference in reduction of the postprandial glucose values. No increase in the risk of hypoglycemia as compared to the rapid acting analogs. So let's skip this. And then in the Pronto type 1 study, which included patients who were more than 18 years of age and had type 1 diabetes for more than 1 year. Here also, there was no difference in terms of HbA1c reduction, so it was comparable. And again, in terms of controlling the postprandial glucose values, there is a significant difference when we compare it with the mealtime Lispro. In terms of improvement in the daytime time in range, there is it was found to be superior. And again, from the hypoglycemia perspective, there is, you can say, with the mealtime ultra rapid Lispro, there was a reduction in nocturnal hypoglycemia as well as overall documented hypoglycemia. So skip this. So in terms of its use of the ultra fast insulin, it is now approved for use. The aspart is also approved for use in gestational diabetes. And in one of the recently published trials, which included around 107 patients, there was no safety issues. As such, no significant difference in terms of A1C when it was compared with the insulin aspart, and there was like a similar fetal growth A1C reduction as compared to insulin aspart in type 1 and type 2 diabetes patients. And we can safely use it in both type 1 and type 2 diabetes during pregnancy as well as in the post-delivery phase. The advantage would be to because we would be able to focus on the 1 hour postprandial control, where most of the studies in pregnancy basically focuses on the 1 hour control. So definitely the faster acting aspart would be helpful in kind of controlling this. Then both these insulins are approved for use in the hybrid closed loop in hybrid closed loop. So here also in one of the studies, there was not much difference in terms of hypoglycemia. Time in range also was not different. So because this can be so both FIASP as well as the aspart can be used for in the insulin pump, basically the hybrid closed loop pump. And then in terms of one of the important uses would be in the chronic kidney disease patients, where because of the fact that we can give it within 20 minutes, so patients with especially stage 5, stage 4, those who are on dialysis, they are prone to hypoglycemia, and then they may have delayed gastric emptying. So this will help in basically matching the insulin peak with the postprandial rise, thereby preventing hypoglycemia. Also, again, a lot of these patients will have poor appetite. So injecting rapid insulin after eating will, again, as per their carb intake, will help in achieving glycemic control without causing hypoglycemia. So and just summarize, so we can kind of focus on this. The aspart, the appearance is within 4 to 5 minutes. Tmax, there is 20, and for the fast-acting Lispro, it is between 10 to 14 minutes. And onset of action is comparable, somewhere around 15 to 20 minutes. And the duration is between 280 to 430 minutes, and here it is around up to 400 minutes. Can give 2 minutes prior and up to 20 minutes post meal. For use in the closed loop system, both aspart, the Fiasp, as well as the ultra rapid insulin can be used in the hybrid closed loop system. It's not advisable in the tandem, although it's not available in India. In pregnancy, aspart is approved. We don't have data regarding the ultra rapid Lispro. Again, for pediatric use, aspart is approved right now. For the ultra rapid insulin Lispro, it is mostly approved for the adult population. Yeah. Thank you so much.
Thank you, sir, for such an exhaustive discussion on ultra-rapid acting insulin analogs. So there is one query from the audience, that is, in outpatient settings, in which subset of patients would you prefer ultra-rapid acting insulin analogs over rapid-acting insulin analogs?
So one would be like where the meal time is variable, and like in that scenario, definitely it would be useful. In pregnancy, gestational diabetes, there definitely one would like kind of use it in certain scenarios. Pediatric patients also, where, I mean, it is difficult to kind of, if the child may or may not eat. So in that scenario, if we have the advantage of giving the insulin immediately after the meal, then it definitely, in type 1 patients, especially in the pediatric age group, it does help. And then wherever there is a variation in terms of the dietary intake, elderly population, chronic kidney disease, where you're not sure, in that scenario, definitely it will have a case use there.
Yeah. Thank you, sir. So I think there are no more queries. So I once again thank sir for his nice deliberation. So now we move on to the last session of today's clinical update. So I invite Dr. Harmandeep ma'am. Ma'am is a senior consultant endocrinology at Medanta, Gurugram. Ma'am will discuss about the hyperglycemia management in non-critically ill hospitalized patients. Over to ma'am.
Yeah, thanks, Rujal. So now we are coming to some practical aspect. This is about inpatient management of hyperglycemia in non-critical care setting, like regular patients getting admitted in wards who are not critical, who are not in ICUs or HDUs. There, how we manage diabetes. So we will start with the case. So very frequently we see such cases like there was a 40-year-old male. He did not have any diabetes history. He was admitted to medicine ward for the workup of pyrexia of unknown origin of 3 months duration. Appetite mildly reduced. His blood sugar on admission was 150, creatinine levels normal. So whenever we find, first of all, like, it is indicated that whenever patient can find blood sugar, any random sugar, to be more than 1, otherwise it may be like even stress-induced diabetes. So at that point in time, we have to confirm what it is. Then you will go for obviously HbA1c, which will give us some idea what kind of diabetes it is. So in this case, HbA1c was found to be 7.5%. So that means patient had pre-existing diabetes, which was not earlier diagnosed. So he has diabetes. Now he will be treated accordingly. So sugars are mildly raised. Obviously, for all practical reasons, we can here imagine that it will be type 2 diabetes only in most case scenarios. So now we will start monitoring. So that is the second step. Here, what protocol we follow is we keep on checking all pre-meal readings, and one post-meal generally we do at post-dinner time. So you can see his readings. His fasting sugar was 160, before lunch it was 200, before dinner 220, after dinner it was 240. Now we will have to take decision like how will we treat his diabetes. So there are many options. So it depends like what kind of scenario you are working in, how well equipped is the hospital, and how is your staff, whether the staff is well versed with insulin or not. So here it is a tertiary care center. So everybody knows how to use insulin, how to check, how to adjust. So most of the times we are working with insulins, but what option you choose? So what options we have? So first of all, the first option generally, which is mostly used, is to start oral anti-hyperglycemic agents. So if we use oral drugs, so is it indicated? Can we use it? So indications for in-hospital use of OHAs, the use is increasing these days. So earlier it was all insulin. Now we have data to suggest that in stable patients, in patients who have mildly raised sugars, you can manage with oral anti-hyperglycemic agents as well. Because we have now the safer ones like metformin. Now we know that it doesn't have many contraindications, and with use over so many years, and even in like early CKD, in mild heart failure, all those scenarios, it has been used. We have a vast experience with it. And even in pre-surgery patients, where we used to stop it 2 weeks before, then it came down to 1 week before, and now the indication is to stop just before surgery. So with all the studies, with all the data which we have now, it is more suggesting that in some scenarios, you can use oral anti-hyperglycemic agents. But here, like this person, if somebody chooses OAD, maybe DPP-4 inhibitor, metformin combination, he will not be wrong, because person is stable, 40-year-old, no comorbidities as such, and creatinine is fine, appetite is okay. So I think starting with OADs will also be a good idea. And HbA1c is just 7.5%. And then the next option is, will you go for sliding scale insulin? So in many hospitals, sliding scale insulin is used, but that will not be a good idea, and we will discuss why not. Then basal bolus insulin regime, which is most frequently used in all tertiary care hospitals where diabetologists are available, where staff is educated. So this is the one which is preferred actually. Can we start pre-mix insulin? Again, you can, but there are hassles with that also. Can we start only basal insulin? So in this scenario, will basal insulin work? I don't think so, because it is like before lunch and before dinner readings, they are higher than your fasting readings. Fasting is not that high. Even if I control fasting, I am little doubtful that it will not be able to control the post-meal spikes. So that is how we go through all the options. So when it has to be insulin. So next we will, in this topic, we will be going one by one, like how to use insulin in hospital setting. So, so we have discussed few things. So here we will be discussing what are the factors deciding the treatment of hyperglycemia in hospitalized patients, what are the glycemic targets, how should we manage hyperglycemia in non-ICU settings? The same case we will discuss later on also, like how we managed and the summary. So we will be going through each of these. So whenever a patient gets admitted, so what are the points we will take in consideration? So first of all, if patient comes with very high sugar, so you have to, here it was a mild hyperglycemia. So person can come with very high sugar as well. It may be more than 300, 400, and many times we get patients with high sugars as well. So you have to decide what kind of diabetes it is, if it is already not typed. So in very high sugars, we are always doubtful whether it is type 1 or type 2, or it can still be stress hyperglycemia, or maybe some drug-induced hyperglycemia. So all kind of scenarios will come into our mind. So if it is, you think it is type 1 diabetes, obviously you have only and only one option, that is insulin. Then it also depends like what are the current blood glucose concentrations. So like liver conditions, if it is hepatitis, or if person is having gastroenteritis, suppose he is vomiting, he has loose motions, obviously you would stop his oral drugs and you will go for insulin. So if there is any organ dysfunction, so then insulin is preferred. Then expected caloric intake, what kind of diet you are planning for the patient. If patient is remaining on normal diet, so then if well-controlled, OAD can also be continued in scenarios where it is indicated. Otherwise, we will go for basal bolus therapy, but in some situations, it might be RT feeding, it may be TPN. So then accordingly, we will choose the therapy. So again, so how you are planning the diet, that will also affect like what kind of regime you will be using for your insulin therapy. Then associated comorbidities we discussed already. So what targets you will set? So here we are following basically the ADA guidelines. So ADA has not changed much over last few years. Still in 2023 also we are following this almost the same targets. So we start treatment for persistent hyperglycemia, and for that the limit is more than 180. Our target is to keep blood sugars within 140 and 180. In hospital, generally we don't allow blood sugars to go below 100 to avoid the risks of hypoglycemia. We all know that whenever patient gets admitted, their diets, they do change, their appetites, they do change because they may not like the hospital food. Their ongoing therapy might change their appetite. There might be some, you can say, tests going on. Patient might fast in between. He might be given light food before some procedures. So all those things, for in hospitals, patients, they increase the risk for hypoglycemia. So generally, we keep blood sugars more than 100. So if any sugar goes below 100, so we definitely will down titrate the insulin. In certain situations where patients, they are already educated, well-versed with their therapy, they know how to use insulin, how to, like the well-educated patients, where they are keeping their sugars in good targets, and the stable patients, and in some situations where you want to be little strict, you can bring it down your target to 110, between 110 and 140. But generally it is not recommended. We know from where all these guidelines have come from, nice sugar trial, that in most of the patients, it is not a good idea to bring the sugars down to very tight control. That also increases the chances of hypoglycemia, and the complications, the morbidity and mortality basically increases. So targets are little lax. So, and there are other situations where patients, they have some severe comorbidities, like in patients with CKD, in patients with liver failure, heart failure. So these are certain situations where you may allow the sugars to be little higher. because in these patients where appetite is fluctuating, patients they are sick, so we don't want any hypoglycemia there. So their targets, we can even allow sugars to go more than 180 as well. And in terminally ill patients, because here we are not looking at the long-term goals, long-term issues. So there we can even allow the readings to be more than 250 as well. So the targets, they depend like what kind of patient you are dealing with and what kind of comorbidities are there, how is the appetite of the patient, what are the chances of hypoglycemia. So in anti-hyperglycemic therapy, we all know, so we have two options. One is OADs, other is sub-Q insulin. OADs are generally not recommended. Sub-Q insulin, as per guidelines, also is recommended for most of the medical surgical patients. And very rarely in wards, we use insulin infusion. Mostly it is used in the ICU settings where staff is very vigilant. They keep on checking every hour, and that is generally not possible in wards, and sometimes it can like lead to severe hypoglycemia. So what kind of insulin therapy should we use? Now we have come to insulin regimes. So first is basal bolus therapy. So you give one long-acting component, and along with that you can give rapid-acting insulin along with the meals. The long-acting, we have the degludec and glargine insulins now. So they are mostly preferred, but otherwise we have also used NPH as basal with regular insulin. So whatever you want to use, you can use both of them. They work very well. Then you can use premix insulin. So as we discussed previously also, premix insulin is not very suitable for hospitals because here you are giving a good amount of insulin for next 12 hours. The first thing is you don't have much chances to control hyperglycemia in between. You will have to wait for 12 hours for your next action. And the next thing is, if patient is planned for something in between, for some investigation, for some suppose patient is going for ultrasound, he's fasting for some time, or any procedure where in between patient might be kept fasting, then you can't do anything. So you have already given premix insulin, so you cannot allow patient to skip lunch and all. You will have to be more vigilant at that time, that it can lead to hypoglycemia in between. So that's why we generally prefer short-acting insulins in between along the meal. So there we are not much worried. So if lunch is getting delayed or if patient is made fasting in between, so there won't be any too much urgency or any hassle of that high chances of hypoglycemia. Then is the sliding scale insulin. So sliding scale, we will discuss more about it in coming slides. So that is not at all recommended, except in very rare situations where, like in sometimes in cases of CKD, say, where appetite is too much fluctuating. Sometimes patients, they are not eating at all, and as we all know that sometimes the sugars are totally normal, and sometimes there are little bit fluctuations in between. Sometimes we do use sliding scale, but not too often. So it is not at all recommended. So preferred approach is basal bolus therapy, and sliding scale strongly discouraged. So what is sliding scale insulin? So most of us, they do know. So during our residency, all the times we keep on using sliding scales. So here the problem is that here the approach is reactive actually. So you see sugar is high, you give some insulin according to your scale, and you bring down the level, and then you let it go up again. So you are not at all acting in between. So whenever sugar goes again very high, more than 200, 250, you checked it, and then again you have given little shot and then you are relaxed. So here what we are doing is basically, so you are producing this roller coaster effect. So you let the sugar rise, you give some insulin, as we can see in the first graph. After the insulin, sugar will come down, but then you are not doing anything. So then you will let it again go up, and then again a small shot of insulin. You are not planning ahead actually. So it is shooting up again and again, and your glycemic control will remain very poor throughout the stay. So this is not allowed. So, so it is in the graph, you can see that patient sometimes, if you have given too much dose, even can go in hypoglycemia basically. So the target range is maintained for a very little time, and most of the times it is overshooting, and sometimes there are chances of hypoglycemia as well. You are not matching it, you are not appropriately managing the diabetes. So here you can see, so if we go for this reactive approach, so the upper graph, so here you are giving insulin only when sugar is high, and again during the day sugar is rising to more than 200 or 250, you are letting it go up all the day. So the average sugars, they remain very high. On the other hand, if you are giving basal bolus therapy, you are you are giving insulin preemptively, you are not letting it rise. So you can give lesser dose, you can try smaller doses initially if you are worried about hypoglycemia. Gradually you can bring it down. You can see like how the graph has come down slowly when you allowed for basal bolus therapy, and by 5th, 6th day it was already in good range. All the like average sugars, they were all in good range. So this is how like we are treating diabetes with basal bolus insulin. So you are giving, if you are giving insulin before meal, even when sugar was like 140 or 150 or even up to like 160, 70, so you are not letting it rise. You are not letting it go above your target. And if it in between, if it is going little high on first or day, second day, you can titrate the therapy. So that is the correct approach actually, not letting it go up. So what kind of insulins we do use? So as basal insulin, you can use NPH insulin, Datimer, Glargine, Glargine 300 is also there, Degludec, all of them, they work very well. Then bolus, what can you use? Dr. Khalid has already very well explained all the benefits and shortcomings of these insulins. You can use short-acting regular insulin, you can use rapid-acting. So these days we have more experience with these rapid-acting insulins, Aspart, Glulicin, Lispro, you can use any of these. And then there are now ultra-rapid-acting insulins as well. So you can choose any of these as preprandial insulin. Then along with this, we also prescribe correction doses. Like if still, suppose first day you have chosen some dose and that may not be adequate for that patient, his next sugar still might go up to 200 or 250. At that time, you had already planned one regular dose, but you will have to correct it for the hyperglycemia which has already happened. So we will match that and then we will give the next dose. So we will see in next few slides how we can do it. So your boluses, they are aligned with meals. Glucose testing should be done before each meal, and accordingly the insulin correction is adjusted along with the regular dose of insulin. So if oral intake is poor in some patients, so we can also give these rapid-acting insulins during the meal or after the meal as well. So if you are not sure whether patient will eat or not, we first allow the patient to eat. So if we see that patient's appetite is okay, he's eating well, you can even plan a shot during the meal, or you can even give it immediately after the meal as well. So that is the beauty of these rapid acting, ultra short acting insulins, that they can be planned even after the meal. So how do we calculate the dose? So in a normal person, so with the ideal body weight, so generally the dose is calculated as we start from little lower dose. You can always titrate up. We don't like to give hypoglycemia, because that is very scary for the patients. So sometimes patients, they don't want to use insulin just because they had one hypoglycemia. So total daily dose you can calculate. In a normal person, it can be 0.4 to 0.5 units per kg. In obese person, we know it is a little higher. You can keep it 0.5 to 0.6. And in lean patients or renal compromise, we all know that requirements, they go down. You can keep it a little lower, like 0.3 to 0.4 units per kg. But definitely this is not the final dose. So we should also know that this is not the final dose. Let the patient also know that you are cautious for hypoglycemia. You are starting from lower dose, and you can always titrate up. So once you have calculated the total dose, we divide it into basal and bolus. Generally, you require 50% of the dose as basal, and rest 50% we divide as boluses pre-meal. So that 50% we equally divide in 3 doses, which will be given with breakfast, lunch, and dinner. And we measure sugar mostly 4 to 5 times a day. And depending upon the blood glucose level, we can also add some correction dose. And basal insulin is titrated as per the fasting sugar. So in this patient, which we discussed already, so we decided actually to give insulin. So as per his reading, so if we try to calculate his dose, so that is the next step now. So his weight is 80 kilograms, and we gave a dose from the lower dose as per his weight. We calculated as per 0.4 units per kg. It came out to be 32 units, and that we will distribute as basal and boluses. So how we will do that? Along with that, we also have to add the correction dose. So that is generally fixed. And we always, there is in our sheets, there is a correction column as well, along with the insulin dose chart. So this is what we prescribed as the correction dose. So what it is, if patient's sugar is between 100 and 180, we will give the dose which has been prescribed. If it is more than 180 but below 220, then we will give 2 units extra. Between 221 and 250, we will give 3 units extra, and between 251 and 300, we will give 4 units extra. So that is how we add the corrections. And if it is less than the target, so obviously we reduce it also. So if we have to divide this dose now, so 50% we are giving as basal, so it will be around 16 units as basal, and then rest of the 16 as the bolus. So we have chosen this dose on very first day, that 6 units we will give with breakfast, 6 with lunch, 4 with dinner, and 16 as basal dose. So let's see his sugars. This is the first day, and these are his readings. So fasting 180, we gave 6 units. Before lunch it was high, so it was 250. So our staff adjusted the dose as per the correction chart and gave 10. So pre-dinner came okay, it was 160. Bedtime was also okay, within the target 180. Now, so for the next day, how will we do it? So next day, day 2, so how we planned, let's see. So here, if we see his sugar, so fasting sugar was 160, as we discussed that basal insulin should be adjusted as per the fasting sugar. So here, because we have given basal only for 1 day, we can wait also, but we chose to give 2 units extra next day. Patient is hospitalized. We are not too much bothered about low sugar here. And morning dose was kept same because we want to see the effect of basal dose the next day. Again, correction chart was used by the staff, and you can see how the sugars behave. Now we know for sure that the pre-lunch sugar is remaining high. So that means that we will have to increase the morning dose of insulin. So breakfast dose doesn't seem to be sufficient for this patient. So what did we do the third day? We increased the morning dose. And what happened with that? You can see the pre-lunch has also fallen in place. So what will you do now? Do you want to wait or you want to do one more correction? So that totally depends upon you here, because it is a very short duration of insulin, just 3 days, and all readings, they seem to be very good. We can just continue with this dose for 1 or 2 days, and we can see the readings. But if we want to be a little more strict, like you want pre-lunch reading to be below 150, so most of the cases, we should try to bring it below 150. And we can again readjust the morning dose, maybe 9 or 10 we can try, because it is just daytime. You can very well see the patient, watch the patient over the day. So hypoglycemia, I don't think would be a big worry here. Patient is healthy, young patient, and his eating is also okay. So that is how we do. Then there are certain special situations. So one is like patient has come with you can say CKD or AKI. So when the GFR is low, so we should take care in these situations. We all know that the insulin requirement decreases basically. So generally, if patient is already on insulin, we down titrate during the hospital admissions, because if such a patient gets admitted, definitely there is some problem. Appetite might come down during hospitalization. Food will be different, patient may not like it, and the chances of hypoglycemia are very high. So generally, we use less doses as compared to their home doses, depending upon, like it will vary patient to patient. If control is very poor at home, obviously we will increase the dose. But if the control was okay at home, generally we down titrate. And we also know that in such cases, the sugars, they fall mostly by the night. Morning sugars, they generally come fine, and these patients may not require night dosing or basal insulin. They may just require the boluses. So there are certain situations like this where basal insulin is generally missed on first day, and we just see the reading. So every patient will not behave the same, we all know. In some CKD patients, insulin resistance is very high and you are giving very high doses of basal insulin. But most of the patients, you don't require the basal dose, and they require very little boluses. And if patient is on dialysis, so there is a tendency for hypoglycemia during the dialysis. Generally, we miss the pre-dialysis dose if it is near to the dialysis time, or we can reduce the dose by 50% also, depending upon the situation. So then the next case is, as we discussed, like we should also see what kind of feed patient will be given. So if patient is put on RT feed, so generally in our hospital, we plan RT feeds every 2 hours. So generally, we give short-acting insulin with alternate feeds. So we give with the morning first feed, then at the third feed, then fifth feed. Accordingly, every 4 hourly, generally, our dose goes. And here, the pre-meal dose of aspart, the aspart boluses, they will be 4 times a day, because feeds are too many here. And then 1 bolus at night, and we will just titrate as we did in the previous patient, and we will also use correction chart as well here. So in summary, so upon admission, we should assess all patients for the history of diabetes, and if it is not there, still we should check the random sugar, and if it is more than 140, we should go for HbA1c. Then we should see what kind of diabetes patient is suffering from. Then we will monitor during the admission if patient has diabetes, and we will try to keep all the sugars between 140 to 180. And insulin therapy is preferred in most of the scenarios. And generally, what kind of insulin therapy is given? That is basal bolus insulin therapy, and sliding scale is not at all appropriate. So that is it. Thank you.
Thank you, ma'am, for such a nice presentation on inpatient hyperglycemia management. So there is just one query, ma'am. Suppose a patient who is optimally controlled on oral anti-diabetic drugs and he requires admission for just 2 to 3 days. So can we continue his existing OADs, which include sulfonylurea as well?
Okay, so you have already given the scenario, patient is well controlled, so HbA1c is fine. So we will have to see like why patient was admitted. So if there is some scenario that patient would be fasting, would be going for some procedure, then there we would be a little worried for the chances of hypoglycemia. We may stop sulfonylurea for a day or two. We can continue rest of the medicines, and then at the discharge, we can continue the same therapy. So we just have to be extra cautious. But if patient is fine, no organ dysfunction, there is no contraindication, we can continue.
Okay, thank you, ma'am. So I think there are no further queries. So
Just a minute.
Yeah,
So
yes.
yeah, we are already past our time. This was our MEND clinic series update 3, which is done by Division of Endocrinology and Diabetes of Medanta, Gurgaon. It is done through Diabetes and Endocrinology Foundation. We thank our speakers today, Dr. Sanjay Mittal, Dr. Khalid, and Dr. Harmandeep for their excellent presentation. And I thank our sponsors. These 3 sessions were, sponsored by Cipla, which is insulin manufacturer in India, both short-acting and long-acting insulins. And we also thank Lupin, which makes oral and glucose-lowering agents like metformin, sitagliptin, and dapagliflozin alone and in combination also. So we thank you all, and we will, our second session of this series will be tomorrow. We have excellent 3 speakers, and I hope all will join tomorrow also. Thank you once again. Over to you, Raju.
Yeah, thank you, sir. So this concludes today's session. So it will be continued tomorrow as well with 3 exciting sessions.
Thank you.
Thank you and good night.